Very much. It's a delight to have you all here. It's great to have our guest speakers here today. So Steve and I co-chair the Social Work Task Force, and we always love to have these webinars as a great opportunity for people to learn lots more of new information from across Europe. So our first person I'm going to introduce is Sheena McKenzie. So Sheena is a counsellor at St Richard's Hospice in Worcester. She is trained in EMDR, FLASH and IFS and is very grateful to her clients for the privilege of witnessing their work. She works with patients and their families as they live with life-limiting illness, and she works with grief and loss, including sudden and traumatic deaths such as traffic collisions and suicide. Sheena has worked at St Richard's since 2019. Previously, she worked in substance misuse for 18 years, and before that, people who were homeless. Her commitment to St Richard's began when they cared for her partner, Ernie, in 2001. It's great to have you here, Sheena, so thank you for that. And Bex has an MA in social work and a long-standing interest in complex mental health needs at the end of life. She's currently undertaking a PhD in trauma-informed palliative care at the University of Lancaster. She combines this with practical frontline work as a bank palliative care social worker at Princess Alice Hospice in Surrey. Most recently, she was awarded a 2024 Churchill Fellowship to explore intergenerational approaches to compassionate communities in Taiwan. So Bex, it's a delight to have you here as well. So without further ado, I would like to hand over to our first speaker.
Thank you so much, Audrey, and thank you everyone for coming along. I'm just going to share my PowerPoint, hoping that works as well as it did a few minutes ago. Here we go. So from beginning. Okay, are you all seeing that? Okay, great. Oh, well, thank you for the introductions, and thank you to all of you for showing up here today. We're going to start off with a poll, a different kind of poll. So this is a Slido. So if you take, oh dear, see, hey, it's already not working. If you go to that QR code, you can take a photo of it with your phone, or you can go to slido.com and put that number in. I think Bex has already put it in the chat. We're just going to populate a word cloud. Yeah, we'll come back to that in a moment, well, in about 20 minutes. So with our time together today, I'm going to speak for about 30 minutes, and I'm kind of offering a kind of broad overview of trauma-informed palliative care. And then Bex is going to speak from a more academic perspective in terms of her PhD work. So I'm really grateful for Bex to offer the kind of academic rigor to this. And then we're going to have 30 minutes Q&A afterwards. So thank you so much to everyone who's already populating the word cloud. We will come back to that. What else would I like to say? So I think there was a previous poll asking you to place your scale on a scale of 1 to 10. So if you see yourself as a leader or expert in the field, then please do get in touch, because we need that expertise and leadership. I would place myself about a 3 and a 4 on that scale. You know, with trauma-informed palliative care, there is so much breadth and depth to the work. So I'm learning all the time. Bex and I have been part of a trauma-informed palliative care working group. And every webinar where we have speakers come and speak, I'm just learning new things all the time. There's just new things to learn always. And if you kind of placed yourself at about a 1 and a 2 in that poll, then please do come. We need everyone to kind of offer their experiences and expertise. So yeah, we're going to come back to these qualities. And I'm very sorry. I believe that when I come out of this slide, then you're not able to put in any more answers, but we will be coming back to it. And there's a reason I'm asking these questions, but it's to be continued. So I can see there's still a couple of people posting, but I will move on now. Oh, will I move on? Will it let me? Yeah, there we go. So I've already done a little bit about structure of our time together, but I would like to say a little bit about me and my work. So this picture was gifted to me on Friday, and it just feels like such a gift, because it shows, and I'll just let you kind of take it in. First self-portrait was painted at one point. 2 weeks later, after a trauma reprocessing, in internal family systems, we call it unburdening. So this person had experienced a traumatic loss, but in a way, her gift to us all was these two images. And that's really the level at which I'm working. So there's something about trauma-informed palliative care that is so systemic, that we're talking about changes not just at an individual level but also at social level. You know, we look at kind of Scotland, which I believe has got an aspiration to trauma-informed care across all arms of government. So education, health, criminal justice is trauma-informed. This is where I make my work. This is the gift that this client's given me today, is to kind of share the impact of what it is like to be free of trauma burdens that you may have been carrying for a very, very long time. And my belief is that working from a trauma-informed perspective may allow people to die with a greater sense of peace, that burden you can see in the first image, something shifted. And that's what I see in my work with patients, is that there's something about having the time and the privilege to witness people place down the burdens they've carried maybe since they were very, very small. So that's where I'm coming from. Really, I'm in the tiny detail. It's not tiny to this person. It's not tiny to the people I'm working with. And it feels like a huge honor and privilege. But also, you know, there's micro and then there's macro. And I'm kind of working at an individual level. So I'm going to talk a little bit about self-care. I'm going to talk a little bit about the University of Death, Trauma and Grief. I'm going to cover a little bit about what is psychological trauma, what do we mean about PTSD, why trauma-informed palliative care, what might it look like. So I'm going to tell you a little story. So this is a story of Kisagotami, and it's a really ancient story. It's thousands of years old, and it's the story of Kisagotami, whose only baby son had died. And he'd been bitten by a snake, and she was just absolutely destroyed by grief. And she was walking from house to house, place to place, village to village, begging people to help her. And nobody could. Everyone was very kind, but nobody could help her because the pain of that loss was so horrendous. And then she met the Buddha. And the Buddha said, yes, I can help you. I need you to get a mustard seed from a house where nobody has died. So she was, oh, that's wonderful. So she went to the first house and they were like, absolutely, have a mustard seed. They're like, oh, but my father died last year. And then the next house, have a mustard seed, but my son died 2 years ago. My aunt, my mother, my daughter, my sister, my beloved dog, you know, every home there was an experience of loss and grief. And so I tell that story really to kind of illustrate that this is a universal experience. And as professionals, we're not outside of humanity. And we might feel very at home about talking about death and dying, but we're also talking about trauma. And when we look at some of the statistics, that might be activating for us in different ways. You know, we are day in, day out, side by side people who are going through the very worst moments of their lives. So we're susceptible, we have vulnerability to vicarious secondary trauma. And also there's a reason that we've chosen the caring professions. You know, we might have our own history. So just, this is really an invitation to do whatever you need to do to take care of yourself throughout this presentation, but also in your work, and with each other, with our colleagues. You know, there's a line from a poem, like, we need to be excessively gentle with ourselves when we're doing this work. So do whatever you need to look after yourself. Take time out if you need to. And this is just a cheeky reference to Bluey. So that story of Kisagotami, it's retold. I don't have any young children, by the way, but Bluey retells that story so beautifully, and just sort of helps us begin to see that we're all impacted by illness, sickness. It's a really lovely story. So trauma-informed palliative care, it's not just about PTSD, it's not just about treating PTSD, as I mentioned before, it's all the way from the receptionist to CEO to local policymakers to government to at an international level. So I'm going to cover a little bit about what is psychological trauma. So the NICE guidelines offer this list. And I've just highlighted there trauma related to serious health problems. So simply the act of receiving life-limiting diagnosis, that may be a traumatic event for someone. And then that's alongside all the other burdens they have carried since they were born, perhaps, or even before they were born. So we know that people have a history, and we also know that a palliative diagnosis could also be traumatic. And there's some broader definitions as well. A traumatic event is one that's unusual and unexpected and causes deep distress to a person. So I really like that definition because it allows kind of broader, more encompassing. It's about the impact on that individual, even if it's not on one of those lists. Some people might have more vulnerability to developing a traumatic response to overwhelming events. This is another definition. A trauma occurs when our usual way of coping and managing our day-to-day experience is overwhelmed. It's frightening and we feel helpless. Our lives may be under threat, or we feel in danger, or we see other people dying or injured. And again, the resonance with our work as palliative care professionals, it's really clear. Our lives may be under threat, or we feel in danger, or we see other people dying or injured. That's the work that we do day in, day out. And Gabor Mate, trauma is not what happens to you. It's what happens inside of you as a result of what's happened to you. So not everyone who has an overwhelming experience go on to develop PTSD. About 1 in 3 people would. So when we talk about PTSD, what are we talking about? So we're talking about intrusions. That might be nightmares or flashbacks. So flashbacks would be reliving an experience rather than remembering it. There's a sense that the memory kind of gets stuck in short-term memory. So when it gets activated, it feels like it's happening now. And because we're tiptoeing through a minefield where we don't know when we're going to be triggered next, or we have a sense of what my trigger is, people develop an avoidance, very understandably. Why would you want to step into something that's going to trigger the worst moment of your life? And you're going to need to relive it. So people will avoid things externally, people, places. Often people report driving a different way to work so they don't have to drive past the hospital. But people might also avoid things internally. So avoid thinking about things, particular feelings, particular physical sensations. And hyperarousal, so the state of hypervigilance, being continually on edge about looking for threat. Yeah. And we know that the prevalence of PTSD varies in the UK by gender, by age. There, we will be working with people who have PTSD. And there is so much thoughtful work out there about how to apply trauma-informed practice in different medical settings. And this is just a really kind of random selection of ways that people are really being very careful and applying trauma-informed principles to different aspects of medicine. Palliative care could be one of them. So I'm just going to read this out because in a way this summarizes why we're gathered here today. So increased stress and trauma may accumulate in hospice and palliative care populations due to normal aging and an increased likelihood of prior intensive medical intervention. Moreover, evidence suggests that memories of old trauma and symptoms of PTSD may be reactivated in normal aging, and that these may be exacerbated by illness and life stress. So if we think about someone who, as a child, didn't have their needs met, they might have experienced neglect, abuse, physical, sexual abuse, and then they grow up into an autonomous adult. They're able to live an independent life where they don't need to turn to other human beings for very much support. And that could work just fine for a person. And then they discover that they have an illness that means their body isn't doing what they want it to do anymore. And they need to turn to other people for perhaps physical care, or emotional support. And if their foundational experiences have been that human beings are not safe, that will be very frightening for a person. And that's what we're talking about today. So the research suggests that people who have a history of trauma in palliative care report more distress. They have increased perceived pain, anxiety, low mood. They find it hard to trust care professionals, maybe other family members. They might present as very angry. They might be avoidant, missing appointments, not engaging, might be the word is non-compliant, isn't it, with treatment regimes. So there's some great research here, kind of really highlighting the importance of this. And not all the literature agrees with it, so agrees with each other. So there's a sense that as we age, we're more exposed to life and more things can go wrong. So as the more time that we're alive, we kind of accrue trauma. And there's a suggestion that 90% of older adults have experienced a traumatic event in their lifetime. Doesn't necessarily mean they go on to develop PTSD, but they may be carrying trauma. This contrasts a little bit with Glick, who describes that older adults report fewer traumatic events and related psychiatric symptoms. And I guess we could have almost like a whole webinar on why that might be. And this, I just thought this was such a sobering statistic. 72% of community dwelling older women report interpersonal trauma, such as physical or sexual abuse or rape. And that has implications for the care that we offer them within palliative care. And again, just more statistics really. Up to 80% of people with advanced recurrent cancer would experience PTSD symptoms. And that contrasts with 20% of people at early stage cancer. And this is a great paper. Really encourage everyone to have a look. Just the real need to develop an evidence-based practice. A lot of the work that I do, I borrow from other disciplines, different settings of things that we think will work. And as that oil painting shows, they do seem to work. But in terms of an evidence base, there is such a need for more research. So what is trauma-informed palliative care? So there's a sense of a realization that trauma affects us as professionals, it affects our patients, their families, or the whole organization, our society. There's kind of a realization that trauma has an impact. And then we begin to be able to recognize the symptoms of trauma. We can recognize it at an individual level. And also we can also recognize the impact it has, a kind of widespread impact of that. And we're able to respond. So we're able to respond at an individual level, but also as an organization, we're able to respond in a way that's attuned to the needs of that individual. And we resist re-traumatization. So in therapy, there are ways of working in order to activate a memory, in order to process it and allow it to move into long-term memory. So as a therapist, we would want to avoid simply having someone relive the horror. And that's true too in all our professions, you know, that we will actively work against triggering someone to relive the worst moments of their lives. Yeah. And that's from SAMHSA, which is the Substance Misuse and Mental Health Services Administration. So that's in America. And then we're looking at the principles. So there's a sense of safety. So we're building a sense of physical safety and also psychologically safety. And we do that in the way that we communicate. And there's something about offering consistent information, being transparent. We're really building a sense of trust with the people we're with. And we can use stories and experiences of other people who've survived trauma. And there's a sense that sometimes we need to be hope merchants, that we hold the hope for people who may not have any, and to let people know that PTSD and trauma, it's not a chronic health condition, it can respond to therapy. Collaboration and mutuality. So in my experience, often kind of hierarchies can be quite steep. So there's a conscious effort to kind of flatten that hierarchy. There's a sense of kind of partnering with the people that we work with, and to share decision-making and power. So there's something about honoring people's autonomy, focusing on their strengths. There's some great screening tools for trauma, but there's also some great screening tools alongside the ACEs, you know, benevolent childhood experiences. What are people's strengths? What are the positive resources they're drawing on to see them through these hard times? Care team providing choices, supporting self-advocacy. And then moving beyond cultural stereotypes and bias, and just really recognizing historical trauma, and listening to the value of cultural traditions. If someone comes into a service where they have particular cultural resources, drawing on them to support them. So this wonderful iceberg is borrowed from Rachel Arundel. So she did a great presentation for the Trauma Informed Palliative Care Network on ACEs and palliative care. So what trauma informed care invites us to do is to see beyond the behaviors. That in a way, all behavior is communication. I mean, that sounds, I imagine, very familiar to everyone. And then beneath the surface, what's going on? What are people's history? What's their experience of power and control, their sense of safety? Are they safe? Are they loved? Are they capable? Is this a place where they can belong? So yeah, we could probably spend all day on just that one iceberg. So I wanted to introduce this psychosocial palliative care model. So when there's not much time, and I really recognize that sometimes there isn't very much time at all, we work to, reduce the symptoms, reduce the disturbance. Sometimes that might be through medication, often through changing the environment, keeping a light on, making sure the door is closed when it needs to be closed, being very clear about what's going to happen next. If there's a little bit more time, we might think about explaining, trauma is a healthy response. Trauma, the fact that my ancestors developed a trauma response in dangerous situations means I'm alive here today. So it's a healthy response to overwhelming circumstances, and kind of reducing the shame around that and beginning to offer some coping skills. And then I guess where I come in, going back to those two images of the oil painting, working to reduce symptoms, releasing people of the burdens that they've been carrying. No, that's not right. Supporting people to release their own burdens. That's what happens so often. I just get to witness it. So there's a lot of discussions in the literature and I'm kind of going to go through this quite quickly. There's a suggestion from one author that practices like EMDR might increase distress and arousal in the short term. But actually, Dr. Leeds, who wrote one of the EMDR textbooks, suggests that if we are assessing appropriately for dissociation, then we're not going to have any surprises. People aren't going to be suddenly flooded with overwhelming memories all at once. And then Gansel suggests that EMDR is at the forefront of possible strategies. And that's certainly what I'm seeing. I'll say a little bit more about that later. So Flash, this just feels like such a promising and gentle way of being able to process memories without having to consciously focus our attention on them. So I just wanted to plant this little seed. There's not time to go into it. It's kind of a side shoot of EMDR therapy, but it's very, very gentle. So Meyerson, we had Dr. Meyerson and Katie Heinrich, part of the team that wrote this paper, come and speak with us. And they've suggested some screening questions just to kind of support people to disclose if they'd like to. There is some suggestion in some literature that we can take a universal precautions approach, and sometimes it might be helpful to ask. Just very gentle invitations to talk about things. So again, we're going to come back to that lovely word cloud. Thank you. So this is exactly what I thought was going to come up. So thank you everyone for filling it in. And I'd like you to, I haven't found a way, I'm not technically gifted enough to find a way to keep those words on the board whilst we look at the principles of trauma-informed care. But I just would like you to kind of hold them in mind, what we're already doing, what we admire in each other, what we appreciate in ourselves. And also the EAPC, there is a sense of excellence, integrity, interprofessional representation, a recognition of EDI, collaboration, sustainability, and the way these map really beautifully onto the principles of trauma-informed care. In a way, we're already doing it, that there's something, I imagine some disciplines, there might be a real jump up to meet the values, the principles of trauma-informed care, but we're already doing it. You know, we're already committed to working with compassion and putting the person at the heart of all the decisions that we make. So safety, trustworthiness, transparency, peer support, collaboration is all there already. So some of this stuff I know might feel like there's a lot of work to do, and that's right at one level, and in another way it's really not. So we're already doing so much of this already. And just, you know, if you are looking at those principles and looking at how you create that kind of systemic change, throughout an organization, there are some really great resources. And it does take change at both the organization and the clinical levels. We don't need to do it all at once. We can just slowly begin, maybe with our staff, maybe with our self-care, like how are we looking after ourselves so we can respond compassionately to behaviors that don't easily elicit a caring response. You know, sometimes people can act in ways that a care team might find very challenging, and it's an invitation to see beyond that, and that starts with looking after ourselves. So there are so many great toolkits out there now. Certainly the resources I've looked at, there are just so much resources, and the toolkit from Scotland's wonderful. I'd also direct you to the Trauma-Informed Care Implementation Resource Centre. There's some really good resources there. And so I'm going to finish with a poem. So, watching my friend pretend her heart isn't breaking. On Earth, just a teaspoon of neutron star would weigh 6 billion tons. 6 billion tons equals the collective weight of every animal on Earth, including the insects, times 3. 6 billion tons sounds impossible until I consider how it is to swallow grief. Just a teaspoon, and one might as well have consumed a neutron star. How dense it is, how it carries inside it the memory of collapse. How difficult it is to move then, how impossible to believe that anything could lift that weight. There are many reasons to treat each other with great tenderness. One is the sheer miracle that we're here together on a planet surrounded by dying stars. One is that we cannot see what anyone else has swallowed. So thank you for listening. Thank you so much.
I think it's for me to share now then, is it? 1 second. Okay, so yeah, hello everybody. Thank you for having me, and I think thank you most of all to Sheena for what was a beautiful presentation that I think really grounds us in this topic, that immerses us in the topic that we're dealing with today. And one thing that I always take away when I hear Sheena speak, not just today, but on other occasions as well, is the passion she has for this topic, for the work that she does, and for, you know, how much she believes in the importance of this approach and the impact that it can have. And I think that passion and that belief is shared by quite a few other professionals. And I say that because it's that passion and that belief that kind of gave birth to this PhD, so to speak, and this body of research that I'm now doing, because this isn't a PhD that I concocted. This was a PhD that was proposed by professionals, members of the Association of Palliative Care Social Workers, and also members of the Trauma-Informed Community of Practice, which Sheena was one of the founding members of. And it's because these professionals saw this stuff, the things that Sheena just described, saw in their practice what was happening, saw that approaches could make a difference, that they felt there was a need to do further research so that we can you know, take this approach further, disseminate it, influence policy maybe, you know, as well. The world is our oyster. So I think that was an important point that I wanted to make. And so the Association of Palliative Care Social Workers went to different universities, and they proposed this, and it was Lancaster that accepted it, and they advertised it as a studentship. which is what I saw advertised and thought this is wonderful because this fits in with my interests and the work that I've seen working in a hospice. And so here I am 1 year down the line. It's a 3-year PhD. I started exactly a year ago. Can't really believe how quickly it's gone. And I thought I'd just take the opportunity today to build on what Sheena has already outlined for us, just to sort of tell you a little bit about the further research that I'm doing to try and build on it. I'm not going to give you a lecture. I'm going to try and keep it as non-researchy as possible. But there are a few things that I've already kind of uncovered, I suppose, that I think would be of interest to the audience today. I know I'm still on slide 1 and I'm rambling on, but there are just 2 more small things I want to say about this. One is it says UK palliative care services in the title. And while it is true that my ambitions are that this piece of research will help the implementation in the UK, that's not to say it's a UK focused piece of research. I mean, I'm looking at what has been done all over the world, because quite honestly, I think there's a lot more has been done outside of the United Kingdom than has been done inside it. And I know we're talking to an international audience today, so I did want to make sure you knew that we're looking at everything. And the other thing is, I am a social worker. I come at this, my positionality when I come towards this piece of research is from that profession, but this isn't necessarily a social work piece of research. Like I know this impacts many palliative care professionals, and I hope to involve as many different types of professions as I can as I go through. So why this PhD? I mean, I think Sheena's already answered that. Trauma-informed care is a concept that first appeared almost 25 years ago in the US by Harris and Fallett. And really, as an approach, it's been gaining a lot of traction all over the world, and especially recently in the UK, it's been applied to more and more services. Sheena showed examples of some research papers of different areas of medical care, but also in mental health, child services. And more recently, we also see it in UK policy. Sheena also talked about, Scotland is kind of ahead of the game, but the UK, government in general has started to release more kind of official policy around it. And now more recently, we're seeing palliative care professionals suggesting that this might be a good approach for our work. And some of the big names that Sheena also shared, like De Groot, Gansel, there's also Brown, Rixahern, they're all building this story, this picture of, this is why it's needed, and this is maybe what it could look like. But despite that, and there's a lot of enthusiasm, in terms of hard, cold facts, there's not necessarily a lot out there. And we definitely don't have evidence of, for example, here's one hospice that has implemented trauma-informed care and here's another that hasn't. What's the difference in outcomes? We haven't got anywhere near, that stage. And to be honest, that's kind of similar for the case for trauma-informed care in general, not just in the palliative care environment. It is an area that, still does suffer from perhaps a lack of consensus around what does it mean? It can mean, some people it's about organizations, some people it's about the individuals. Lots of definitions sort of flying around. Some of them we spoke about in Sheena's presentation, such as the one from the US, the Substance and Mental Health Services Administration. The UK government has a working definition. And then any organization might have their own definition or their own way of implementing it. So apart from that, we also don't necessarily know, how do we measure its effectiveness? What outcomes are we sort of expecting from it? And I think it's, like in all areas of practice, it's kind of important to try and get a little bit more clarity on some of that, because if we haven't got a strong evidence base or a stronger evidence base, then we're at risk that this approach gets sort of misinterpreted or watered down or lost amongst all those other policies and approaches that we see. So you're not supposed to be able to see the detail of this slide. And in fact, I'm glad that you cannot, but I just wanted to put it up there as to kind of give you some idea of the chaos, or how I tried to organize the chaos that was in my brain when I first started on this PhD, because I realized quite quickly that there were a lot of questions to be answered. So I sort of split it up into two things. On the right-hand side, you've got the what. So what is trauma-informed palliative care? Well, within that, we've already got other questions, right? What is trauma-informed care? I've already just said how there's different definitions. But then what is palliative care? Because that itself isn't something which is, the definition of that keeps expanding. And it's now, it could be talking about palliative therapy many years before death. Other organizations include bereavement care as part of palliative care services. So when we're talking about trauma-informed palliative care, are we talking about the same thing at all of those stages, or how will it change? And then on the left-hand side, you've got the why question, which is, so why even implement this approach? And Sheena's presentation and the many discussion papers from people like Gans and de Groot do give some suggestions of why, but what's the actual evidence? Is there, what studies do we have around how trauma impacts the end-of-life experience? What studies do we have around the prevalence of trauma or PTSD in people who are dying, or in family members of people who are dying? And what evidence do we have that these kind of approaches are effective? So once we've got some answers to some of that, that's when you can start to get down to the bottom, when you think about the how, which will be, what might this look like in practice? I imagine there's more than one version. Like I just said, there's different types of palliative care. There's probably different versions of trauma-informed palliative care. So how should we apply this? What might be the barriers? What might be the facilitators? And we get much more into the implementation stage. So that's like a lot. And my PhD is definitely not going to answer it all. It's trying to maybe answer some of the bits in the red, some of the what, and some of the why. And then hopefully that will help future researchers or people as they are thinking about studies that could get closer to building an actual fully conceptualized and tested model. Okay, and oh, did I want to start? Yeah, okay. I did. So an outline of what I am planning to do. So it's a PhD by publication, which means that I do 4 separate papers, which hopefully get published, and then they'll all come together with a nice story and thread into the final piece. So I've already nearly finished my scoping review, which is a bit like a literature review, just to try and see what evidence do we have at the moment. And then I'm doing a survey, which I'll talk a bit more about at the end, with some social workers. And then after that, I have to have a little bit of a think about what type of qualitative work I want to do. Definitely we'll look at some other palliative care professional groups, maybe with interviews. I'd love to do a study with patients and families, but you probably know, or you can imagine at least, that palliative care research with patients and families is quite difficult to get ethical approval. There's lots of things to think about, recruitment and timing and appropriateness and so on. So it could be possible, but it's something to think about. And another option might be to do a Delphi study with thought leaders, which is kind of an iterative process to help try and get consensus, perhaps on what the principles, for example, that might define trauma-informed care compared to trauma-informed palliative care, what might make it different, what might be some of the specific principles compared to just trauma-informed care in general. So I knew when I started out that there wasn't going to be a whole lot of research, well, a lot of research on actually implementing trauma-informed palliative care. So I had to cast a wider net to try and get a bit more of a basis. So basically what my scoping review is doing is just to see what is out there in the literature that it talks about psychological trauma at the end of life. And how do those papers, how do they describe some of the concepts that may be relevant to trauma-informed palliative care? So I didn't realize quite how wide that was when I did cast that net, but it was pretty wide. Before I go into some of the results, very top line, I just want to say that this is disclaimer that this is still work in progress, still being analysed. So if you see this in a paper at some other time and it's like got a slightly different number here or there, please, that's because it's not quite there. Not have crossed all the T's and dotted the I's yet. So again, you don't need to read the detail of this, but for those of you who are familiar with Prisma diagrams, this kind of just shows you how you found your papers. and from what sources and how many you've ended up including in your review. So when I said I cast the net wide, I think I had over 3,000 papers that came up. I looked across 6 databases using words like trauma and palliative care, end of life, like combinations of those things. Once I screened all of those and so on, I've got down to 78 studies now that are in my review, which is still a fair few, it turns out. And I just wanted to mention, I had to make some quite difficult decisions about what to exclude, and some decisions that I don't necessarily feel comfortable with, or I wish it was a different way. But I had to keep focused. So for example, I decided not to include studies that looked at bereavement care, not because I don't think it's an important part of palliative care, but because it's kind of a whole other PhD in itself, trauma-informed bereavement care. And I also excluded studies that were looking at palliative care input in intensive care units, also things like assisted dying and suicide. And the toughest one that I had to leave out was secondary trauma and compassion fatigue. And I say it's the toughest one because trauma-informed palliative care, as Sheena said, is really an organizational approach, and it does put a lot of emphasis on the trauma experienced vicariously by the professionals. However, there's quite a lot of research out there at the moment on secondary trauma, also especially around COVID-19, and I didn't want it to kind of muddy what I was trying to do. So that is there's lots more other PhDs. If anyone's interested, I can think about 5 or 6 more other trauma-informed areas that need to be properly looked at. So in terms of results, so you can see here, big concentration of papers from the US, as we'd expect, considering that the concept first originated from there, like I said, back in the early 2000s. Then, Europe-wide, that 10 is over Greece, which makes it look like Greece is very well represented, but those are all papers from one particular author and research site. So that's slightly skewed. But there were, papers from the UK, from Australia, Canada, Israel, Japan, Rwanda, and one from Switzerland, I think. So an international flavor. Only papers that were in English I looked at. So there could be papers out there, of course, in other languages. In terms of the type of research that's been done, the majority has been qualitative, and that is mostly because I included case studies. That's a kind of a controversial, I'm allowed to do that because it's a scoping review and I'm allowed to be kind of flexible, but obviously case studies aren't seen by a lot of people don't see case studies as a particularly robust source of evidence. It's often just 1 or 2 practitioners reflecting on 1 or 2 cases. But actually, when you take all the case studies together, which I've been able to do in this review, and I think there's 29 case studies I had, when you take them together as a chunk and you start seeing some of the themes that come across them, they actually start to become more of an interesting source of evidence. And I think, case studies for a topic such as this are particularly interesting because, it is so practice-based that I think there is a lot of wisdom that is within all of our minds of what we're doing and what we've seen, that hasn't necessarily gone through a thorough research, study. So I do appreciate the case study, just to say that. In terms of quantitative papers, so they often focused on PTSD, and I suppose that is because it's a diagnosis that can be, you can use a structured clinical interview to decide whether someone fits the criteria for diagnosis or not. So that makes it easier to do a quantitative study on. So they might look, for example, these studies might look at the prevalence of PTSD amongst a veteran population or amongst patients with advanced cancer. But there was also quantitative studies looking at other concepts like post-traumatic growth and other measures of psychological distress with sort of self-report questionnaires. In terms of who were the study participants, the majority of papers looked directly at patients, but there were a fair few that sought the perspectives of family members or caregivers. And sometimes, in terms of family members, sometimes that was because they were asking the family members to sort of report on how the patients trauma symptoms were affecting their or impacting their end of life experience. But in other times, it was the family members themselves who were the ones who had experienced the trauma. So, for example, there's a few papers out there that talk about the experiences if you've been abused as a child by a parent, and then you become the caregiver for that parent later in life. What does that mean? What does that look like? What might be some of the triggers for re-traumatization there? And those are some, I mean, there was just papers things I hadn't really thought about before, but it's just really interesting findings, especially around language, adult children who had been abused, talking about how professionals maybe in the hospice might say things to them like, you must love your dad, or why don't you, sit there and hold his hand, or trying to ask them to get more involved in physical care, or you must want to sit with them after death, things like that, which actually for some people that's just not the case. That's not the nature of relationship. So slight diversion there, but so things about family members. And then in terms of professionals, so there's a fair few papers looking at education, the effectiveness of education of PTSD education mostly to professionals. And there are a couple of studies there that looked at actual trauma education about trauma-informed approaches. And then other studies sort of took the perspective of professionals about how did they see trauma manifesting itself in their patients. So as I had suspected, there weren't many papers that implemented trauma-informed care. So I had the 78, a third of the papers named or maybe described it, but a lot of those was just maybe in the conclusion, like a recommendation, like this is what we think about trauma. We should probably implement trauma-informed care, but they didn't actually do it themselves. So out of the 13 papers which did, 9 of those were case studies. So Sheena mentioned some of those papers already today. Some of them go into quite a lot of detail and sort of take you through step by step. Like, these are the principles of trauma-informed care, and this is how we applied it to this patient, and this is the results. And again, taken together, some of those it's quite powerful. The other ones that implemented, 2 of them were looking at homelessness and provision of trauma-informed shelters for the homeless population, and the other 2 were about education to professionals. So I mentioned most of these already, but just some other highlights, I suppose, if you want to call it highlights. It depends how exciting you find this. So there were case studies. SPPC is what Sheena referred to earlier, the stepwise psychosocial palliative care model by Feldman. His model is specifically looking at PTSD, but I don't see a reason why. I mean, I think when you read it, you realize that it's relevant to, it's very similar to the trauma-informed care principles that we see from other organizations. I spoke about the quantitative studies. So veterans and cancer were 2 things that were very common. So common, I mean, 43, over half the studies, cancer was the primary diagnosis for the majority of patients. And that's probably a reflection of palliative care research in general, that, there are obviously many other palliative end-of-life conditions, but cancer does seem to sort of have more of a weight when it comes to research. And then veterans, that also wasn't a surprise, one, because of the link between veterans and PTSD, also because it's quite a widely studied area in the US. So yeah, but there were papers from other countries as well looking at veterans. Challenges around structural vulnerability. So I already spoke about homelessness. I think there were 9 papers on homelessness, but other papers looked at refugees. They looked at the intergenerational trauma, racial trauma. There was a paper on food poverty or food insecurity. So it was talking about the removal of, I'm not going to be able to think of the right phrase now, the removal of like artificial feeding at the end of life, and how, for a family that has come from food insecurity, how that can be, the traumatic impact of that. So lots of different types of trauma. And then there were also papers that were focused on more, I suppose, positive impacts like post-traumatic growth. And some of these sort of did both. They looked at post-traumatic growth and PTSD, and some very interesting findings amongst all of that. So I'm not going to go into all of this in any great detail, because I think our time is nearly done. But just to give you a flavour, what I then did is I looked at how do, we've got this body of research, which isn't necessarily on trauma-informed palliative care per se, but it is relevant in the sense that it is research that acknowledges psychological trauma at the end of life, right? So in that research, what can we see about how do they describe different concepts? For example, how do they describe the impacts of psychological trauma? And lots of things came up that fit with what we've seen in the papers. For example, the paper by De Groot, so resistance to care or treatment is probably the biggest one that comes up. People just disengagement with services, discharging themselves, not wanting physical care, not wanting medical treatment, a bunch of impaired communication with providers or with family members, complicated caregiving for both professionals finding it difficult to know what to do, and also for informal caregivers, also for like this study is talking about the child abuse that I mentioned before, and then other things like increased clinical needs, so maybe more difficult to manage symptoms, requiring more admissions, things like that. And then the one on the far right, disclosure and perspective, it's kind of the opposite to the resistance or the communication challenges, because there are findings that say that the more traumatic events people had, the more likely they were to, for example, engage with preparatory grief, or to disclose, or to have post-traumatic growth, like things like that. So have a different perspective. And then there were just two more. Oh, I've lost my bit. Oh, there were just two more things that I looked at. One, I was looking at how do studies describe not trauma-informed palliative care, but approaches that along those lines, I suppose. And it's that things that came up are very much in line with the trauma-informed principles. Building relationship buildings, putting the patient at the care. Sorry, putting the patient at the center, advocating for them to have perhaps a more flexible approach to care because of their different needs, sort of advocating for professionals to work in different ways and together as an MDT. And then, thinking what Sheen just talked about showed those examples of screening questionnaires. So there's a lot of, should we assess? At least we need to be aware, or we need to be thinking about this. And then evidence-based interventions, which would be the things like that Sheena mentioned, and I can't see because and improved end of life experiences. So a lot of studies, especially the case studies, pointed to really positive changes when when palliative care that recognized psychological trauma was implemented. And then, finally, it was just looking at what might be some of the challenges. And these are challenges that we could come up with ourselves, I think. It's really difficult to assess for PTSD, it seems, actually. It can be, especially at the end of life, it can really get confused with delirium. And a lot of studies found that some patients didn't have any symptoms of PTSD their whole life until the last few days. And then if it happens at the last few days, you've lost the window to treat it properly. So then what part of the what stage of approach do you go in at? How can you help when it's really days or hours left? Also some just uncomfortableness about talking about this. How can I bring up these questions? How can I is it appropriate to share with the rest of the team when I find out that someone's had a trauma history? Talked about implementation, time constraints and the rest of it, but it's not just time constraints, but resource constraints. So not everyone has a Sheena at their hospice, right? We certainly don't have anyone in my hospice who's qualified to deliver evidence-based interventions like the ones that Sheena does. So what do you do in that case? Need for more evidence. There's always need for more evidence. And then I think structural vulnerabilities, I said there was quite a lot of papers that that talked about that. But I think, you know, the general issues around access and inequalities in palliative care for groups such as the homeless, those experiencing homelessness, come through in this as well, right? They have an even greater need for trauma-informed palliative care often, but because of barriers to access, it can be difficult. Okay, so when I mean discussion, I mean like my conclusion, not that we're going to have a discussion. We don't have to have a discussion about this. What did I get to? That yes, like I said, apart from case studies, there is limited empirical research on, in brackets, trauma, in quotes even, trauma-informed palliative care. But what this scope review has done is to identify a substantial, and it is substantial because it's taken me a really long time to go through it, body of literature that is really relevant to its approach and describes concepts relevant to its approach. And we know that much work often happens just not under the title of something, which is what, you know, I was trying to show here. And my real hope from this paper is that by extracting all this, analysing it, presenting it nicely, this will help those who are designing and developing future studies to take the next step. And I'm just going to speak about in 30 seconds because I need to promote it, the survey I'm doing. So my second piece of research, which is out and live, is a survey which is just for palliative care social workers. That's not because I don't care about the opinions of other professionals, but there are, in terms of getting like a more homogenous study group, and also one I've got better access to, or at least I thought I did, then that's why I've chosen social care workers for the moment. But like I said, the later studies will look at other groups. And yeah, I'm trying to get 100 to 150. I have not got that yet, which is why I'm about to promote this. So if you know any palliative care social worker who has worked at any point in the UK, then it would be fabulous if you could, or if you yourself or one could share this with them, and I can put the details in at another point. But yes, that is where I am so far. The work continues. There's still 2 more years, and so lots more to learn. But yeah, I'm really enjoying it. So that's the main thing. And that's it. Thank you.
Sorry, I took a little moment to mute then and turn my camera on, but thank you both for that. There's so much I personally am going to take away from this. I think the thing that really resonated for me in Sheena's presentation was her saying, what's going on beneath the behavior? It's an invitation to see beyond. And I think that really sits often for those of us who work in social work and work in an MDT. I think that's a question that we as social workers often ask. I think certainly in my team, sometimes behaviors will get labeled with families that we're working with and patients that we're working with. And I think it's often our role that that has to kind of advocate for and ask the team to understand what's going on. And the other thing that I really took away from your presentation, Bex, is, you know, you just kept talking about the evidence base, and you kept talking about empirical studies. And I think one of the things I've always felt as a social worker is that, you know, we're not that good at kind of having evidence for what we do. And I just found that really, really refreshing. And I hope you crack on and get this published, and, you know, can actually change how people think about and practice, and, you know, and adds to the evidence base. So thank you both for that. We've got some questions, and I'm actually going to start with a question that was asked when somebody actually registered for the webinar. Is how do we introduce trauma-informed care into a palliative ward? I don't know which one of you wants to have a go at that.
So in a way, I'm not qualified to answer because there's something about taking a leadership role and beginning to introduce these concepts. But in my direct experience, it's simply beginning to talk about trauma as a thing. You know, at the very, very beginning, it's having those conversations. So I've been invited on to our inpatient unit to offer supervision to groups of nurses, and be able to kind of unpick things through a trauma-informed lens has been really helpful. And that's because those nurses have been willing to talk to me about those things and willing to show up when the ward might be very busy. In terms of the bigger picture, I would really direct you to Scotland's Trauma Informed Toolkit, because that walks you through it little step by little step. And that other website that I shared, I can't remember what it's called, Trauma Informed Resource Centre, I think it's called. They really break it down in a way that doesn't feel like it's going to give you indigestion. So kind of for people who are in more leadership roles, you know, to begin to look at how, you know, you look at every policy. We had a recent presentation from the managers of a family support counselling service. And I must admit, I felt a little daunted. You know, I think they went through 76 different policies with a trauma-informed lens. You know, how do we shift this? So it's easy to feel daunted, but also please don't feel daunted, because that quote that I put in there about it can happen gradually. We had a professor of EMDR come and speak to our whole hospice about trauma. He was a great speaker, Derek Farrell, and it wasn't just the counselling team that went to that. You know, there were representations from different people across the hospice. So it's beginning to have that conversation, beginning to have that realization. I don't know if that answers it.
Thank you. Bex, did you want to say
Yeah, I mean, I echo what Sheena said. I think it's and also something that she said in her presentation, where that it can be, you know, trauma-informed care can really be about something on the individual level, or an intervention that you're doing one-on-one. And then it could also be as big as the whole organization taking an internal trauma-informed care to the way it treats its staff and so on. So it's vast. I think that you know, education and training of staff is the first step. You know, awareness that that this could be the explanation for some of the behavior that we, or the more challenging behaviors, or whatever you want to call them, that we may see. And even I've just done some education in the hospice before, and even just opening people's eyes to like, this might have been the reason this person might have acted like this, or is maybe because of this. We're trying to show them the relationship between triggers and behavior, I think can make a big difference, because then people just start sort of thinking a bit more. And I think that's where it begins, because it doesn't have to be about following a set of guidelines or rules. I think sometimes it's just about opening yourself up to the possibility there might be a different reason behind things, and taking that into consideration.
Thank you. It seems to me it's like you kind of have to sort of make a mind shift to sort of think a slightly different way. And I just wonder, just following on from that question, how I might, you know, like yourself, Bex, I work in a multidisciplinary team. How might I kind of just get that seed in people's minds without expecting them to do you know, read a document or go on some training? How might we just get people to start thinking differently?
Yeah, so I think in some of the case study papers, a lot of which are written by social workers, actually, they say that maybe like the first step is not necessarily involving if there's a particular patient in the hospice or on the ward, and it appears that they may have had a past history of trauma, or they may be displaying post-traumatic stress disorder symptoms, then it's kind of taking that moment at the MDT, just even 2 minutes out of the time, just to give a bit of psychoeducation to the professionals themselves, along the lines of what I just said. So sort of just say, but have you thought that maybe it could be because of this? Or have we thought about ways that is this person feeling unsafe in any way, and that we could maybe change something in their environment which may make them feel safer? And sharing that, I think that's what they kind of recommend, at least in these papers, as the first step, before going to necessarily talk to the patient themselves, just sharing amongst the MDT team when you've got a moment.
Okay. Oh, that's really helpful. Thank you. Another question that was actually put when people registered originally is how trauma-informed dementia care impacts with palliative care. It might be interacts with palliative care. Does that make any sense to either of you?
I don't mind trying to answer. I mean, I think this sort of reminds me a bit of what I said about how trauma symptoms can often be diagnosed or not spotted. I'm losing my words a bit, sorry. They may be mistaken, for something else. So, for example, the symptoms of delirium or terminal delirium at the end of life, people aren't quite sure sometimes if that's PTSD or delirium or what it is. So I think when it comes to something like dementia, it's a similar kind of problem, isn't it? Because it's hard to know what are the symptoms of dementia and what are the symptoms that may be to do with PTSD and how do they overlap. So my feeling would be that you would take the same types of approaches in order to try and help people feel safe, removing environmental triggers, but you may have to do it just like you always do when looking after people with reduced mental capacity. You kind of have to do it with their best interests and kind of trying to understand what, without them being able to necessarily always verbalize it or explain it to you, trying to get underneath that a bit. But the same as we always do when we're dealing with mental capacity, I think. So I don't know. I can tell you that nothing came up in my research that was specifically looking at dementia, but I think it's an excellent question and something else to add to the list. I'll let Sheena.
And I'm not jumping in from my direct experience, only that I remembered that Myosin, one of her case studies was about both and. So someone with cognitive decline and PTSD. It was a story of Scott. And then she breaks it up into the trauma-informed principles and how they responded to his cognitive decline that was combined with his history of trauma and PTSD. So if people are curious, that might be a good case study to look at.
It's a very good point.
I mean, I find that really interesting because I think you said Bex, wasn't it? There was like 5 or 6 other areas where you could have, and you not rejected, but you didn't include them in your review. Can I just ask, because I'm particularly interested in bereavement care, and I'm also think that this could apply very strongly to bereavement. Just roughly, do you think how many papers you had to deselect because they were specifically about bereavement?
Oh, what a question. I mean, it's difficult to categorize it exactly. I mean, if they were well, I mean, I could definitely in the tens, if not up to 100 or something. I mean, there's definitely papers that are looking at the trauma of people who've witnessed a traumatic death. Like I said, COVID has, I think, accelerated some of the research around that. People who weren't able to be with their loved ones when they died. So there's definitely recognition of that kind of trauma, just as there's papers that recognize, the trauma of a sudden death and death in the intensive care unit. There's quite a lot of research around that. But intensive care is a difficult one, isn't it? Because it can have palliative care input, and it does obviously have a palliative care angle to it, but at the same time it's sort of, they're two very different environments that have different original goals, right? One is very much about treatment and the other one is about that alleviating symptoms. So it's hard to merge all of those papers together, but yeah, there's a lot out there. I can send you some if you're interested.
Yeah, no, I just think that'd be a fascinating way of looking at it, so thank you for that. I'm just going to move on to some other questions. So Audrey actually asked a question, even though she's one of the facilitators, saying, I've lost it now. Any research studies involving people in prison with palliative care cancer? And then Jeanette, actually, you wouldn't be aware of this, actually said she used ChatGPT to look up and says there's actually she's found 8 references. So I don't know whether she's already answered that question or whether you want to elaborate on that.
I mean, that slightly worried me, Jeanette, I've got to say, because those 8 papers aren't amongst my 78, so I'll have to double check that. There's definitely papers that include case studies for people who've got lived experience of prison. So maybe who've come out of prison, often maybe overlapping with people who are experiencing homelessness. There is a paper by Deppner, which I think was the basis of a movie, actually, which takes a different look at things, but it's very interesting. It looks at the they do have what they call an inpatient palliative care program. So the actual inpatient, don't mean inpatient, I mean inmate. Thank you. So the inmates themselves are trained in providing palliative care to other inmates. And and I think a few prisons in the US have done this, and they've got results which show a lot of beneficial impacts on symptoms of PTSD or maybe positive changes in post-traumatic growth amongst the inmates themselves who are giving the care. So it comes at it from a slightly different angle, but it's also a very interesting one. So yeah, but I don't know about the other 8 papers that Sheena mentions, that Jeanette mentions, but I'll have a look.
Yeah, maybe if Jeanette can share that with you afterwards, that'd be great. So, interesting question, though, an interesting way of looking at it. We've also got a question from Dr. Shani John Sequeira. Apologies if I'm not pronouncing your name correctly. Did you find any studies involving nurses as recipients of care themselves?
No, so by that, do you mean nurses who were working as nurses and then became unwell? Is that what that means?
Don't know if Shani's in the chat, maybe we could come back to that one then. Oh, she has put something, but I don't think that was that right now. Yes, nurses. Yeah. Do you mind just elaborate? Nurses as patients?
No, I did not. I mean, it could be that some of the background of some of the patients, their profession wasn't previously nurse, but there was no paper that particularly looked at that. But I can see what you mean, as in, I mean, it's something I think about quite a lot. When people have been caregivers who have, worked in a hospital or a hospice giving palliative care, what happens when they themselves need to receive that care? It is interesting to think about how they may respond differently to a person who hasn't worked in that role. But no, I haven't found any papers about that.
Okay, thank you for that. Another question for you, Bex, as well here, especially from Joanne. She was really struck by your example of encouraging physical contact with a dying person when that might not be the right thing to do, but finding the words to manage that is difficult. Do you think a guideline similar to our EAPC recommendations on the LGBTQ plus inclusive care might be valuable for palliative care professionals?
Yeah, definitely. I mean, I think a lot of organizations are working on how they do assessments, right? At the beginning, when a patient or a family comes to their services, they're working on how do they take that information around topics such as how, pronouns and things related to LGBT plus care, what may be some things that the organization needs to be aware of for that person in particular. And it kind of, I think in terms of trauma, it's the same thing. I think it's actually just part of the same conversation. I think it's almost like ideally, it would be great if when someone came into our services from the very beginning, we were able to ascertain from them, what is it that we should know about you that might make your care, I'm not using the right words, but trickier, or what might be some of the things, and it'll be different for every people. Some people, the fact that they are a part of the LGBT plus population may not bother them in terms of their care. They're not worried, but there may be something else that's about a past trauma that does worry them. So I think I see it as all of one, right? What might be the things that are triggering to you? What should we know about you? What can we so we can make you feel safe, so we can tailor our care? So yes, I suppose it is about recommendations. I feel I'm always conflicted about, do we need guidelines for like everything, like a trauma-informed guideline, an LGBT plus guideline, whatever else guideline, or do we maybe about discrimination and race? Or it's important because we have to make sure that we are addressing all those areas, but at the same time, some of it just seems about, I don't know, humanity, just all of it, like one big guideline about how to be sensitive and to all that there is in a human, all the facets. I don't know, maybe I'm getting too philosophical there, but I think you know what I mean.
And I think that you were saying there just really reminded me of Harvey Chochinov's dignity question, that what do we need to know about you to provide the best sort of care? I think I'm paraphrasing, but that sounded quite similar really to what he advocates. Yeah.
And I think many we do get close to that. And I know a lot of hospices and things have, about me forms, and they do try. I think there's a lot of great work going out on to try and get a picture of a person. I suppose it's maybe when it comes to trauma, it's just thinking a little bit more about triggers and particular environmental situations, or things like Sheena said, keeping the light on, or people always introducing themselves when they walk in the room, not being overcrowded with too many professionals, or whatever it may be. I mean, there's tons of examples in the papers that Sheena shared about triggers. Sorry if I'm going back a little bit to what you asked earlier, Stephen, about how could you maybe like help professionals to be aware of this. And I think providing them with some of the trigger examples is really powerful. So for some of them seem quite extreme, but there's, a paper that talks about people receiving palliative care in Israel who have been Holocaust survivors. And when they're asked to, come for a shower, or we're going to take you for a shower. Like, that seems like a very extreme example, but that's the kind of thing that if once you share that with other professionals, that maybe they may think, oh, okay. We had an example at the hospice of somebody who every time we had different colored plates for food, depending on the consistency of the food. And so he was always getting a red plate because it was soft diet or something. And every time he got a red plate, he, smashed it in the air, and it turns out, he fought in the war, and it reminds him of a flag. And so there's lots of different examples like that, and I think putting those together can open people up a bit more to like, wow, if that can trigger someone, think of all the small things that might be happening.
Sure. I do wonder whether Joanne's also fishing to get you to do some guidelines for her.
Right.
Well. And she's also encouraging you, as we would encourage anybody who's on the call, to put in an abstract at EAPC. EAPC is in Helsinki in 2025, but the closing date for the abstracts is the end of the month. So just to be aware of that. But both for you and Sheena, there's definitely, I think that's one way of you broadening, your net and people, educating people about this. So thank you for that. We do have we've got probably time for maybe one more question. And this is from Hui Ju. Again, apologies if I'm not saying your name correctly. Have there been any discussions on trauma which may be experienced by the patient or family members and its relation to spiritual care in the context of end-of-life care? Great question.
I feel like I'm jumping. I keep jumping, but I suppose if it's, I mean, yes, I think there's a lot of papers that talk about the input of a spiritual care team, or sometimes they name it as chaplaincy, or other times they call it spiritual care. And I think when a organization doesn't have a qualified professional like Sheena, who's able to deliver specific trauma interventions, it does seem to be a theme in the literature that a spiritual care team can, and also they do talk about social work a lot, but spiritual care comes a lot, can help in those situations and be very effective. There's some case studies of spiritual care teams, and they explain how they sort of helped individuals to work through their trauma and kind of come to some forgiveness at the end of life and acceptance, to reconnect with family sometimes. And then to accept care itself. I don't know if that's answering the question.
Want me to ask it again?
I don't, or I'm not sure if that was quite right or not. I mean, there's definitely stuff that comes up about. There's definitely part of the impact of trauma at the end of life can be spiritual distress and existential distress. So that's one thing. And then I think part of the solution definitely is involving the whole MDT team, part of which would be the spiritual care team, and that they can definitely have a big role to play. If that answers it, let me know. If not, I'm not sure.
Brilliant. Thank you for that. I will also say Sheena's do you want to come in, Sheena?
Just very briefly, Derek Scott has written on trauma and spiritual experience. He died recently. He's got a book coming out. So from an internal family systems, in a way that's kind of implicit in everything that internal family systems does. And we've had conversations in the trauma-informed palliative care working group about having someone from a kind of chaplaincy or spiritual care team coming to talk to that perspective. Had a really interesting conversation with a vicar about trauma theology, which is apparently another aspect of theology, looking at the Bible through a trauma lens. How we interpret the Bible will be as a result of our own experiences. So he was coming at that from a Christian perspective. But just to say, if anyone is part of a chaplaincy or spiritual care team, we would love to hear that perspective as part of the network. And also, yeah, check out Derek Scott's work.
And also Sylvia has said spirituality is often overlaid by religious trauma that comes out at the end of life, which I think is a really interesting way of looking at it. So so thank you to everyone. I was just going to say thank you both, Sheena and Bex. Really, I mean, certainly I've taken a lot away from this, and I will certainly take it back to my team. Also, just to say, whilst you're probably giving your presentation, didn't realise there was we got up to about 64, 65 people at one point, which I think is fantastic, which just shows the interest in the subject matter. But also, we had people from Australia, India, Myanmar, Poland, Germany, Borneo, Bangladesh. So you really have had an international audience today, so thank you very much for that. So and I hope we can hear from you again, and both of you carry on with the great work that you're doing. Sylvia's saying Sheena would love to work with you and we'll be in touch, and she's from Houston, Texas. So again, the USA, Ghana, there's so many different countries, so that's grand. Thank you so much to everyone. Joanne, Joanne's asked everybody to complete an evaluation form and download their certificate of attendance, and that link is in the chat. I would also say to Sheena and Bex, have a look at the chat, because there's some lovely comments in there with the comments that people have said and how they're going to take stuff back to their team as well. So that's really good to hear as well. Audrey, did you want to say anything?
Just to say thank you very much. It really resonated with me a lot based on some of the work I've been doing recently with prisoners or people in prison, and access to palliative care service. And like yourself, Bex, I noticed that in prisons it's generally those people who are diagnosed with cancer who seem to be then considered for compassionate or early release and compassionate grounds, so they don't really think about it for other life-limiting conditions. But also it made me wonder, because we see quite a few people when we looked at their illness trajectory who either missed or refused to go to hospital appointments for that final diagnosis after, being referred on that pathway for 14-day diagnostics, and or who have then decided not to engage in treatment, or who refused to go into the palliative care suite or to be moved out of their wing where they would receive much more intimate care. So interesting, because obviously there's a high population of people in prison who have experienced trauma. So yes, it certainly has given me a different lens to think about how we look at some of that data and present that. So thank you very much.